Hi, my name is Jaiswal. I'm one of the third-year internal medicine residents here at OSU. Today, I'll be doing my senior thesis over aortic stenosis, and I'll be primarily talking about the diagnosis and the management of aortic stenosis. So just a brief outline of everything we're going to talk today. I'm going to talk about the definition of aortic stenosis. I'll touch a little bit about the background and some epidemiology relevant to your clinical practice. I will talk about etiologies for aortic stenosis. I'll also talk about symptoms and key characteristics you'll see when you're performing your physical examination. I'll talk about how to diagnose AS. I'll talk about the different types of managements, interventions, and then just a brief summary with a list of my references to follow. So just a brief definition of aortic stenosis. Aortic stenosis is the narrowing of the aortic valve. It's usually caused by calcification. This usually causes an obstruction of blood flow from the left ventricle to the aorta. Here's a good picture image of a healthy aortic valve versus a stenotic calcified aortic valve. Obviously, one on top is opening and closing regularly. You don't see any calcifications on the valve. On the bottom picture, you'll see that while the aortic valve opens and closes, you can see the different type of closure it can perform and the calcifications surrounding the valve. And you can see that it has kind of an incomplete closure kind of through here. So just to briefly touch on some background in epidemiology, aortic stenosis is the most common valvular disease in elderly population. And it's noted that 1 of 8 people that are over 75 years old have moderate to severe aortic stenosis. So this is something you'll see in your clinical practice. Some etiologies of aortic stenosis include congenitally abnormal valves. You might have patients with bicuspid valves. You can have calcification of the trileaflet valve in the elderly populations. You can have aortic stenosis from rheumatic valvular disease. You'll have other less common causes such as Fabry's disease, lupus, alkalinuria, Turner syndrome. There's 3 different types of aortic stenosis. When we define it, we characterize it as mild, moderate, and severe. Here's a good table demonstrating how we grade aortic stenosis in the 3 different categories of mild, moderate, severe. We look at peak velocities, mean gradients, aortic valve areas, and velocity ratios. As an internal medicine resident and for the future resident class, it's crucial that you guys understand and identify the severity and grading of aortic stenosis, specifically in regards to peak velocities, mean gradients, and aortic valve area. Someone tells you you have a peak velocity of greater than 4, a mean gradient greater than 4, or a valve area less than 1, that should immediately make you think that your patient's suffering from severe aortic stenosis. So when we talk about aortic stenosis, they have 3 symptoms that are most common. The 3 most common symptoms are dyspnea on exertion, syncope, and angina. The most common symptom of aortic stenosis is dyspnea and decreased exercise tolerance. This is likely due to diastolic dysfunction that causes an increase in LV filling pressures with exercise, and it also has an ability of the LV to increase the cardiac output during exercise. One of the second symptoms that patients with aortic stenosis present with is dizziness or syncope. About 10% of patients with symptomatic severe aortic stenosis may present with dizziness, and this can also, just like I said, be a presenting symptom of aortic stenosis. There's 4 different kinds of pathophysiology that can explain dizziness and syncope when you relate it to AS. One's exercise-induced vasodilation in the presence of an obstruction with the fixed cardiac output that causes hypotension. The second one's transient bradyarrhythmia during or after exertion. The third one is an abnormality in the baroreceptor response, which causes a failure to increase blood pressure. And the fourth and final possible explanation is patients suffering from atrial or ventricular arrhythmias. The third most common symptom associated with aortic stenosis is angina. It's important to note that half of patients with aortic stenosis usually have underlying coronary artery disease. It's also pertinent to realize that coronary artery disease can be seen in a minority of patients without angina who also have severe AS. So it's interesting that you'd think that how can patients have angina but not have coronary artery disease? There's 4 real mechanisms that possibly can explain angina in patients without coronary artery disease that cause myocardial ischemia. One is that you have an increased total LV oxygen demand due to the increased LV mass from aortic stenosis. Another one is a reduced coronary flow reserve that causes and is related to myocardial and vascular factors. You can have an elevated diastolic pressure that causes reduction in perfusion pressure gradients, or you can have a reduced diastolic coronary perfusion time during tachycardia. While these 3 symptoms are common, they're not specific, and many patients are asymptomatic for a prolonged period of time despite increasing and worsening obstructions. So as an internal medicine resident, when you're on service, when you're on your cardiology rotation at OSU, it's pertinent to know these 3 presenting symptoms. It's sometimes difficult to kind of remember which symptoms are associated with it. So one saying I heard when I was in medical school and in residency is that patients with aortic stenosis are sad. It's easy to remember and easy to not forget. So S is for syncope, A is for angina, and D is for dyspnea on exertion. So for the interns, the incoming interns, and I guess some of the PGY2s and PGY3s, physical exam is probably one of the most important factors where we can diagnose and further stratify if a patient has aortic stenosis. It's important to note that the physical examination does correlate with the severity of aortic stenosis. And some physical examination findings would include low volume and slow rising of a cardiac pulse, a loud mid to late peaking systolic murmur in the right intercostal space, and a single second heart sound. So whenever you're performing your physical examination in respect to the carotid pulse, you have parvis and tardis, which is low volume and slow rising. It's best appreciated in the carotid artery where the pulse is reduced in amplitude and delayed in occurrence. Cardiac auscultation is probably the most important physical exam finding that as internists you guys can for sure examine. Second heart sound is usually soft and single. You have a paradoxically split S2 with severe stenosis and LV dysfunction. S1's usually normal, but an aortic ejection click can be heard with congenital bicuspid valve. And the most common physical exam finding you'll see on auscultation is a systolic ejection murmur, which is best appreciated at the base of the heart, which is in the right intercostal space. If you have an early peaking murmur, it can indicate mild to moderate aortic stenosis. If you have a late peaking murmur, it can indicate more severe aortic stenosis. So after your clinical suspicion for aortic stenosis is kind of founded, the main way to diagnosis is by performing echocardiography. At OSU, we have our butterfly echocardiogram. So if you guys are in the wards or in the ICU and you guys are concerned that one of your patients has aortic stenosis, absolutely grab the ultrasound, take a look at their aortic valves. You can easily tell if it's tricuspid, and you can kind of estimate if it's having a full closure or not through your examination. Like I said, echocardiogram is a primary test and the kind of gold standard for diagnosis and further evaluation of aortic stenosis. You can also have an EKG or chest x-ray performed in these patients that you're concerned about aortic stenosis, though neither one of them is necessary or diagnostic. You might see atypical findings on EKG, including arrhythmia such as atrial fibrillation or LVH. You might find some abnormal chest radiographic findings. You might see some calcifications, but you may also rule out other causes of your patients who have angina and syncope with chest radiography as well. So transthoracic echocardiography is kind of the gold standard, as I discussed. You'll see aortic leaflet thickening and calcifications. You'll notice that there's reduced leaflet excursion. You may see a bicuspid aortic valve that demonstrates two leaflets. And you'll also want to do Doppler measurements on these patients, and you'll be able to obtain velocities, gradients, and subsequent valve areas. Here's an image of a normal aortic valve. I guess wanted you guys to see. See if I can pull it up. Here's a aortic valve that's tri-leaflet, opening and closing well, no real issues, no overt obvious calcifications that you'll see. I wanted you guys to also see an echo of someone who has pretty severe aortic stenosis here. Here you can see the valve not really opening and closing appropriately. You can see some calcifications, and these are kind of some signs that you will be concerned that they have aortic stenosis. So whenever you have patients who have aortic stenosis, you'll notice that our patient population are patients who are elderly, which is one of the most common risk factors for developing aortic stenosis. So if these people have calcifications on their aortic valve, you may be concerned that they have calcifications elsewhere in their body. So if they have one or more of these symptoms, it's an indication to perform cardiac catheterization as well. These symptoms can include progressive angina, objective evidence of ischemia or asymptomatic or symptomatic LV dysfunction. It's important that when you're performing cardiac catheterization, you're aware that crossing the aortic valve may be difficult if you want to obtain like an LV-gram. You also can have increased risk of embolization off of the calcification of your aortic valve and cause things like stroke. So I have to be very, very careful when performing cardiac catheterizations with these people. If you have patients with asymptomatic severe aortic stenosis identified on echocardiography, you can always exercise test these people to see if their severe symptomatic aortic stenosis is actually symptomatic or not. Patients who have severe aortic stenosis that's asymptomatic develop any symptoms at all on exercise stress tests, including exertional dyspnea, they should be considered symptomatic as well. You can also have low-grade aortic stenosis, and patients who have low-grade aortic stenosis may have low-dose dobutamine stress echocardiography for further stratification. Computed tomography can also be performed in patients with low-grade aortic stenosis that have inconclusive dobutamine stress echocardiography. Complications of aortic stenosis include heart failure. A lot of patients with aortic stenosis have LVH with normal systolic function. You will also see some patients develop diastolic dysfunction due to hypertrophy and fibrosis, and this diastolic dysfunction may persist after a valve replacement and may not be fully reversed after having a definite correction of your aortic valve. Some patients, like I said, may have systolic heart failure as well. Ventricular dysfunction due to valve obstruction usually improves, though, pretty soon after valvular replacement. You have pulmonary hypertension. Pulmonary pressures will be increased in AS due to elevated diastolic filling pressures. You may see severely elevated pulmonary pressures greater than 50 millimeters of mercury, and this can occur in up to 15% of patients with AS. The biggest complication and concern for patients with aortic stenosis is sudden cardiac death. Obviously, symptomatic severe AS has a higher risk of sudden cardiac death. If you have patients with severe asymptomatic AS, the annual incidence of sudden cardiac death is approximately 1%. In patients with severe symptomatic aortic stenosis, the annual incidence of sudden cardiac death is 8 to 34%. The other complication we worry about is arrhythmias. They can occur, but they're relatively uncommon. You can see intraventricular or atrioventricular conduction abnormalities due to the severe hypertrophy. You can see ventricular arrhythmias due to LV dysfunction in patients who have systolic heart failure. You likely may see atrial fibrillation that can occur. And like I said, they're more common in patients who have other risk factors, including older age, LVH, and LV dysfunction. And the most common arrhythmia in patients with severe aortic stenosis is atrial fibrillation. Another complication you'll see with aortic stenosis is endocarditis. It can occur in patients with AS, specifically those with congenital bicuspid aortic valves as well. Excuse me. Another complication is bleeding. This is something that you likely will be tested over on your in-service or cardiology boards, or just be pimped from one of our attendings about. So patients who have aortic stenosis are at increased risk of bleeding due to chronic gastrointestinal bleeding due to angiodysplasias. You'll also see some bleeding at the skin and mucosal sites. The association of gastrointestinal bleeding and calcified aortic stenosis has been termed, I think I said it right, Heide syndrome. The increased risk of bleeding is due to an acquired von Willebrand syndrome. This abnormality is a resultant of mechanical disruption of von Willebrand multimers during turbulent passage through your neurocalcified valve and due to interactions between von Willebrand's factors and platelets that trigger platelet clearance. This is something really important to know. So now that you know what aortic stenosis is, know what the physical exam findings are, know how to diagnose it, your next step is kind of managing aortic stenosis. In patients who are absolutely completely asymptomatic, really recommend serial echocardiography in these patients, usually every 6 to 12 months. You want to try to prevent these patients' disease from progression. You want to make sure you adequately control their blood pressure. You want to make sure these patients are physically active, exercising. And even though you're doing everything you can for these patients, keeping them healthy, keeping them on a good diet, keeping them with good blood pressure management, they can still develop worsening aortic stenosis and LV dysfunction, which at the end of the day still needs valvular correction. Patients who have symptomatic aortic stenosis can have replacement of their aortic valves. You want to make sure they're euvolemic, and patients who have severe symptomatic aortic stenosis need to be carefully managed, as those awaiting valvular correction can destabilize quickly, and you want to make sure any medical intervention you perform will benefit the patient. Here's a good kind of flow chart I found online that kind of discuss everything we talked about. Kind of shows your severe aortic stenosis, shows your velocities, shows if you're symptomatic, shows if you're asymptomatic, and tells you kind of which class of aortic replacement it is. If there's class 1, grade 1, 2A, 2B, or 2A. This is just a good table to look at as a reference. So now that you know your patient needs an aortic valve, you always have to consider the different interventions you can do to benefit your patients. The first one people sometimes will think about is percutaneous balloon dilation. It's usually a bridge to actual aortic valve replacement, and sometimes this can be used in palliative measures. So your patients who are critically ill, who are elder, who have multiple comorbidities, who don't want to undergo valvular replacement, may have more comorbidities that may take their life sooner than later, and doing a balloon is palliative in nature. Serious complications with ballooning their valve can occur. These risks are real and they're there. They can occur in 10 to 20% of your patients. They can have stroke, aortic regurg, or myocardial infarction. But the big thing to know is that restenosis and clinical deterioration do occur in 6 months to 12 months, and long-term outcomes are similar to those patients who are untreated for aortic stenosis. So ballooning is more palliative or a bridge to definite management. So now that you know the first intervention you can do for aortic stenosis, it's time to kind of discuss surgical versus transcatheter management of aortic valve. Whenever you consider performing definite management of aortic stenosis, you need to make sure that you have a multidisciplinary team discussion that includes the nursing staff, the anesthesiologist, the primary team, which is us, your primary cardiologist, the interventional or structural cardiologist who will be performing the procedure in conjunction with the cardiothoracic surgeon. The Society of Thoracic Surgery have a predicted risk of mortality, which is abbreviated the STS-PROM. And when you're kind of having that multidisciplinary team discussion, you need to realize which category these patients' surgical risk is in. If they're in the highest surgical risk, their risk of death or serious irreversible complication is greater than 50%. And if they have severe symptomatic aortic stenosis, TAVR is recommended. If they're high surgical risk, so if their STS-PROM score is greater than 8 and they have less than a 50% probability of death and severe symptomatic aortic stenosis, transcatheter aortic valve replacement can be performed if transfemoral anatomy allows. If you're unable to do a transfemoral TAVR, you should definitely have a team discussion if there can be consideration for alternate access site TAVR versus a SAVR, the surgical aortic valve replacement. If your patient falls in between the intermediate surgical risk, so their STS-PROM score is 4 to 8 and they have severe symptomatic aortic stenosis, TAVR is still appropriate if they don't have any high-risk features. They kind of defined high-risk features as adverse aortic roots, low coronary arterial heights, heavily calcified bicuspid valves, and severe LVOT calcifications. There's always consideration for the surgical aortic valve replacement if transfemoral TAVR is not feasible. And if it's transfemoral TAVR is not feasible, obviously have the risk-benefit discussion with your patient and the team for alternate access site TAVR versus SAVR. If your patients are low surgical risk, which is defined as an STS-PROM score of less than 4, they're greater than 65 years old, are able to have a transfemoral TAVR, they have a trileaflet aortic valve, and they don't have any of the high-risk anatomic features that I discussed, TAVR should be performed. If one or more of these features are not present, open surgical aortic valve replacement should be considered and is preferred. So here is another good chart that kind of discusses everything I talked about. It talks about making sure your patient's life expectancy is greater than 1 year and having a risk assessment on your patients. So if they're extremely high risk, high surgical risk, intermediate risk, or low surgical risk, it shows the different recommendations that I discussed. So at the end of the day, there's a lot of options to discuss with the teams, but you should always, always, always have a multidisciplinary team discussion and always to make sure that your patient's part of this conversation. They may have one thought process versus another and always include them in their decision making. So if surgical intervention is thought to be the best management for definite correction of aortic stenosis, you kind of get to the point where you want to discuss with your cardiothoracic surgeons which type of valve is preferred, if you want to use a bioprosthetic valve and mechanical valve. Both have their risks and benefits. If you use a bioprosthetic valve, they last about 10 to 15 years, but they don't need long-term anticoagulation. You can get away with 3 to 6 months. I put twice there for anticoagulation, but they also have a higher risk of a valvular deterioration. If you're going to use a mechanical valve, they last quite a bit longer, but they have to be on lifelong anticoagulation. Here's my favorite recommendation, which would be a transcatheter intervention. This is a Edwards Sapien 3 valve that can be placed transfemorally. Here's actually a good picture I found online. I follow a lot of cardiologists and a lot of echo stuff on Instagram, and this was a picture I saw, I think like a few days ago or so, that actually show a patient under fluoro and kind of what you're looking at, what you should see when performing a TAVR. You'll see the pigtail catheter for contrast. You'll actually see the Edwards Sapien valve. You'll see the wire that's in the LV. You'll see the pacer wire you place as each patient can develop conduction delays. Let's see here. I think I have a picture video of the valves. Let's see if I can get this. This is a video of TAVR with an Edwards Sapien 3 valve, kind of a mirror image of everything we discussed and I just showed. You see them ballooning the valve, you see them pacing the heart, you see the valve expanding within the balloon. So after your patients have TAVR, you can also have some post-procedural care. Patients who have TAVRs need echocardiography prior to discharge and close interval follow-up. They should be seeing their cardiologist soon after having TAVR performed. Usually these people can be discharged very, very soon after having this procedure performed. They usually need echoes in 1 month, 6 months, 12 months, and then annually thereafter. These patients also need to be on dual antiplatelet therapy with aspirin and Plavix, as they're at increased risk for leaflet thrombosis. It's kind of dependent on the structural cardiologist, but they're usually anticoagulating them, using dual antiplatelet therapy for 3 to 6 months. They'll usually stop Plavix and have them on lifelong aspirin monotherapy, but then it kind of is the provider's preference. There's not definite guidelines on dual antiplatelet therapy, but there has been real leaflet thrombosis being seen. You can also have complications with TAVR, such as perivalvular leaks, so routine echocardiography is appropriate. And always make sure your patient's symptoms are improving and aren't worsening. So in summary, the clinical examination and the history are key for the initial steps in diagnosis of a patient who comes in that you're concerned may have aortic stenosis. Echocardiography is the recommended diagnostic approach. As the fourth-year medical students who just graduated or just becoming interns and are on the floor, you listen to a patient, they have a systolic murmur, and you're worried they have AS, feel free to go downstairs, feel free to grab the butterfly valve and take a look for yourself. Order a formal echo, call me, ask me if your patients are severe. Let me know if you're concerned that they might need valvular replacement sooner than later. We'll be happy to see them. And like I said, whenever these patients need valves, make sure every member of the team's kind of contacted and as part of a conversation, including the patient and the family, as the therapies are vastly different and your patient may benefit from one or the other. Here are my references. Thanks for listening to me talk about aortic stenosis. If you guys have any questions or concerns regarding aortic stenosis, echocardiography, TAVRs, open valves, feel free to call me, email me about anything. Thanks.